looking and considering suitable speakers for tonight, and speaking to several people with experience in this area and who have consulted with both professors and rabbis in this area, I got quite a number of people suggesting the same speaker and the same speakers. Professor Kate Stern of the University of Melbourne. She also heads the unit on endocrinology at Royal Women's Hospital. Also at Melbourne IVF. Her primary area is fertility preservation, and she's very passionate about that. I'm looking forward to hearing some more detail, though we got some basic introduction in the video about the science and the technology of egg freezing, and after that we'll introduce Rabbi Greenbaum for some details and views on the Jewish ethics of this issue.
And thank you very much for coming to listen tonight. So that was actually a very interesting video, and it was at least 85% accurate, I think. I found it quite enlightening. I've watched it a couple of times now, and I got a little irritated when they said that professional people couldn't give balanced views, but apart from that, I think it was quite illuminating. And it did show you the complexity of the issues, the medical issues and the ethical issues associated with egg freezing. So I'm just going to talk a little bit about this from a medical point of view. So what do we need for fertility? Well, the most important thing we need is good eggs. And that's why I've got this picture here with the eggs bigger than the sperm and the uterus. Because really the most important thing for fertility is the health and the goodness of a woman's eggs. And the major problem that we face in fertility for our patients is women's age. It's harder to get pregnant and it's harder to stay pregnant. And when people come to see us to discuss their fertility, the first question, and it's always hard to ask, is to ask, how old are you, and then how long have you been trying to get pregnant? And age is the most important factor. And you can see here, this is live births, having a baby, actually with IVF cycles, but the graph is exactly the same with spontaneous fertility. So that you can see that really from the early 30s, the success of having a baby from an IVF cycle or spontaneous conception drops down quite precipitously, and it's very difficult. And I think really even in this sort of, in our well-educated patients, people don't realise, because women will keep having their menstrual cycles till they're 50, but from the age of about 38 to 40, the eggs aren't very good. So I think that we have this sort of false sense of security about the eggs. So what happens is that you have a reduced egg number and reduced egg quality. So this is just a picture to show you an egg. It's just so beautiful. I just didn't really have a good reason for putting it in, but just wanted to put it there to show you how beautiful they are. And this is the ovarian tissue from a girl aged 20. So you can see all these little white discs. So they're the follicles that have the eggs in them. And this is the ovarian tissue from a woman aged 42. And you might just see one or two. So this is just average. You can see how dramatic the difference is in the number of eggs. And what happens, so we've talked about reduced egg number, and now I just want to talk to you a little bit about reduced egg quality. So what happens is the chromosomes which carry the genetic material become very scrambled and dysfunctional. Somebody, when I showed this slide one day, said that looked like my hair compared to someone glamorous's hair. And so every time I look at that, I have a shudder and think about how did I do my hair today. But this just shows complete disorganisation of the spindle, which is just the line on which the chromosomes lie. And you can see it's quite a dramatic difference. So this is what happens in the eggs of a woman who's 40 compared to a girl of 20. And we know that we have increased miscarriage risks as we get older. So for a girl aged 25, she probably has about approximately 18% chance of having a miscarriage in the first trimester of pregnancy. but a woman aged 40 has at least a 25 to 32% chance of having a miscarriage, and that reflects the chromosomal abnormalities. As the eggs get older, the DNA repair mechanisms of the chromosomes get much worse, and that's why you have these increased chromosomal aberrations. So a lot of women will come to their GP or to their fertility specialist and say, can I check my fertility? I need to know what it's like. How am I going, you know? And the answer is that we can help you find that out a little bit, but not really very conclusively. We can do pre-pregnancy screens, and we can, you know, scrutinise the cycles, the menstrual cycles, to see if they seem to be ovulatory. There's a blood test called AMH, which is called anti-Müllerian hormone. An anti-Müllerian hormone is a reflection of all the little eggs we have in our ovaries. So in our ovaries we have thousands and thousands and thousands of little eggs, and as we go through the cycle you might end up with one ovulating each month. So AMH is really reflecting this pool of follicles. And it's a very commonly prescribed test, and the problems with it is you order that test for a patient and then it comes back pretty average, and that has really big significance for the patient. So the counselling side of this is very complicated. And this is a graph. It looks complicated, but each little blue dot or triangle is a woman. This is over 3,200 women, just showing you the AMH results. Really, you just have to look at this shadow here, the red line, and it just shows you how at your maximum fertility your AMH is quite high and how it deteriorates. But the other thing that I want you to look at is the range. So you can see in every age bracket, you can see there's enormous range of women, and that red line is just the average. So if a young woman goes to a doctor and has her blood test done for her AMH, let's say she's 29, and it comes back here, so it's still within the middle range of 50%, 50th centile, but, you know, a bit below the average, that woman is going to be very difficult to explain to her that actually that's okay, because she'll think her AMH is low, that means her ovarian reserve is low, she's not going to be able to get pregnant and have babies. And she'll, you know, we see it day after day, these women come in upset, depressed, really worried, and we try and explain this, and they're much reassured, and they've had a lot of sleepless nights and a lot of worries, and sometimes considered quite drastic steps because of it. So you have to be very careful with this test. So there is such a large variety of normal. It's really important that the doctors that prescribe it understand that. The other thing about AMH, while it gives you some sort of idea of your egg number, it doesn't tell you about the health of your eggs. And that's very important, because you might be 40 and have quite a good lot of eggs for your age, but they're still going to be 90% abnormal, like anyone else who's this age. It doesn't tell you how many years left, and that's very frustrating for young women that come in wanting to know, how long have I got, how much more time have I got? This test really doesn't reassure you completely. And the other thing is that you can still successfully get pregnant and have a baby when your AMH is very low. It's important to understand that. So what sort of options are there available for young women to preserve fertility? You know, in popular press, I think they talked about it a little bit on the video, they talk about social fertility preservation or social infertility, and there's a big move to sort of get rid of that, because that has some sort of connotations which are quite adverse. We like to think of it as what we call elective fertility preservation. Now, it's interesting when you look in the media, and on that video today, you would think that the vast majority of women who are coming wanting to do egg freezing are women who are busy, climbing up the corporate ladder, very busy with their work, and are making these conscious decisions that they want to preserve to hold off fertility because they want to keep working and do better with their work. And it's, you know, it's one of those really tiresome stereotypes, because that is not what we see. You know, the press love it. Every time I have to do interviews, they're always talking about, don't you think it's selfish of these women and blah, 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 they've got all these choices, and it's complete rubbish. So I just wanted to show you.
It's not true what they're saying. You're saying people are not pushing it off because of work.
Well, a small percentage are, yeah. So this is some data from a very good study in 2013, which was a good study looking at lots of women, and it had very rigorous questionnaires, and it reflects what we see in clinical practice. So yes, there are some women that do that. Of course, there are some women that do that are trying to make sure that they can get into a good position financially. But the vast majority of women we see nowadays are women for whom it just hasn't worked out the way they want it to. They've been in a relationship and the relationship's broken down, or they haven't been successful in having a relationship. And really, most of the women that we see are women who are 37, 38, and very sad that life hasn't gone the way they wanted it to. They didn't deliberately put off their fertility, they just weren't in good relationships. And there was a slide which I didn't put in here, which just shows the differential populations of men and women around Australia, and along the eastern seaboard, we're much more overpopulated with women. So I think there are some women who want to who make choices deliberately to delay their fertility, but that is a convenient stereotype and that is not the majority of women.
Are these Australian figures or American figures?
This is an American study, but there's a study done in Australia that reflects this exactly. Yeah. So I'm just going to go through very quickly about the actual process because I think the video did quite well. This is just showing, they were talking about the American Society of Reproductive Medicine acknowledging that egg freezing was not experimental. So from when I first started practicing, which was quite a long time ago, egg freezing was quite experimental. And it's important to explain that the science for this came from cancer patients and women whose fertility was being taken away from them by having their cancer treatment. And that's what's driven this whole thing. It didn't come from this sort of social framework. All the research was done originally because we had patients coming to us who were having chemotherapy and going to lose their fertility, and what could we do? And around the world, the same thing happened. So this is just demonstrating that European society, like the American society, finally said, look, actually egg freezing is pretty good now. The success rates of thawing out are reasonable, so we're not going to, and there have been thousands of babies born, many more thousands than they said there, and we're going to not call this experimental anymore. So as they graphically showed you in that video, what happens is you see your specialist, and I think it's important to say that maybe 60 to 70% of the women that come to us to talk about this, we end up not going ahead with. So I think, responsible doctors, like responsible people in all other professions, are not going to be deliberately spruiking for business and putting women through these cycles without educating them well and informing them well. So there's a process of consultation and evaluation. We talk about the risks and the benefits, and I'll talk about those a little bit more. And our patients will have counselling sessions with the counsellors and the nurses. And then they have 10 to 14 days of these little injections. We actually only use one injection for most of the days and then 3 or 4 days with a little second injection. When you looked at the medications that woman was on, 3 of them were unnecessary. And this is just showing you, this is a normal ovary here with lots of little follicles. I don't know how well you can see it with the light, but this is what happens with stimulation. So you can see there are about 8 big follicles. Now, that doctor called them eggs. They're not. They're the follicles, which is like the balloons that the eggs live in. And then with the ultrasound, as you saw, we take the eggs. And the patients are usually under sedation. They're asleep, but it's not a general anaesthetic. Now, on average, we might get about 10 eggs for women under 37, 38, and then it goes down after that. And as they discussed, there are 2 processes to freeze eggs. We used to do what was called slow freezing, and now we do what's called vitrification. That's just a rapid freezing technique. Actually, for many years, the slow freezing, the results were reasonable. About 60 to 70% of eggs would survive the freezing thawing process, but now with this new technology, approximately 85 to 90% of eggs would. But once the egg has survived, it's then got a very, very long journey. So the egg has to get fertilised. This is later on down the track, and this is a video. So this is the egg. It's been fertilised. It's now an embryo, and you can see here it's gone to 4 cells, and this is what happens over 5 days. So this is an embryo 5 days after fertilisation. So we made that in only a few seconds, but you can see that there's a big process that the egg is going to have to undergo after it's been thawed out to make the embryo. And everybody's always asking about the numbers with very good reason. And when they were talking about all those numbers before, they didn't tell you what the denominators were. They weren't saying 70% of this or 3% of that. So it's completely impossible to understand what they're saying when they don't tell you what the denominator is. So this is some fairly simple data, but it's very accurate data. So for every 10 eggs that we take, and people say, oh, how many eggs are you going to get? Well, you'll get whatever you get. Some women might have 3 or 4, some might have 15 or 20. You just take whatever you can get after the stimulation. But for every 10 eggs, approximately 9 eggs will survive later down the track when you want to use them. Only about half will fertilise, and that was the first day of the picture that I just showed you. But ultimately, when you get down to day 5, which is the time that you put embryos in, you may have between 1 and 3 embryos. If the woman is young, you might have 3 embryos. If she's older, you might only have 1. So what we're saying is between 10 and 30% of those eggs will make embryos. And we say to patients on average, because our patients are usually mid-30s, on average we'll get 1.2 embryos for every 10 eggs. So that's just a bit more than 1 opportunity to conceive from every 10 eggs. Now, if you make 30 eggs, hopefully you'll get a few more opportunities. And I think that's why that doctor was saying to that woman, oh, we want you to do it again.
Does that mean that if out of 10 eggs, only 1 or 2 become embryos, does that mean the others weren't fertilised properly, or they just didn't freeze properly, or how?
No, so this is all natural, what we call attrition. This is. There's not that there's something wrong. This is what happens. A lot of eggs will have the wrong numbers of chromosomes, even in young women, so they weren't fertilised. Some sperm aren't that great. So the best that you get is 50 to 60% of your eggs fertilising. That's in the real world. That's just nature. That's what happens, and you'll get 1 or 2. And also, once they get to that point, that doesn't mean they're going to be normal. This is what you get. So this is a natural process. Now, when they talked about how many eggs are needed to get pregnant, I don't know if you remember, there was a page they showed that had 3 graphs on it, which was published in the New England Journal. And I actually had that slide in and then I took it out, because that slide shows that if you're under 35, for every 6 eggs that you freeze, you've got a 30% chance of getting pregnant. Now, that is based on accurate data, but most people's experience is that it just sounds overly optimistic. And so we've done an analysis in our laboratory which reflects other units. And I agree with them, there is a lot of hype. So they were sort of showing that 70 to 80%. So that would be if you were under 25 when you froze and you had 10 eggs, which is really not the real life situation. So with our data, and it reflects the best Australian data, if you get 15 to 20 eggs frozen, and it doesn't matter whether that's 1 or 3 cycles, but altogether, and you are under 38, then you've got approximately a 30 to 50% chance of getting pregnant. Okay, and you can see here, this is the average number of eggs to get a live birth. So you can see from your mid-30s, it starts going up fairly rapidly.
So the rates of clinical pregnancy that progress to live birth?
Yeah, I think I've got that next slide. No. So I'll talk about this in a sec. So this shows you that there's no difference between eggs that have been frozen making embryos and fresh eggs in IVF. So pregnancy rates for every good embryo are approximately the same from fresh and frozen eggs. So that's important. You're not comparing it to spontaneous fertility. You're saying once that egg has survived the freezing thawing process, and 90% will, it will behave like a fresh egg in IVF. Now, the next question is, for every egg that you get, and you might get on average 10 eggs, what's the chance of that egg actually making a live birth? And that what did they talk about in there? They said between 2 and 15%. And our data is that on average 7 to 7.5% chance of a live birth from one egg. And the important thing to compare that to is normal IVF with fresh IVF when you're not doing, you're not freezing the eggs, and that's 8%. So that confirms this data. It supports the same data. So if a patient and her partner come into us and do IVF, and we're not freezing the eggs, we're just doing IVF and making an embryo and putting that embryo in, we're talking about the clinical pregnancy rate from that. And I'm comparing that to if a woman comes in on her own and wants to freeze her eggs. And so the additional process you have is the freezing and thawing. So what we're interested in is once that egg survives, is it just like a fresh egg? And the answer is yes. So if you look at it per egg, only 7 or 8% of eggs will make a baby. But that's sort of less relevant than when you get a cohort of 10 eggs, what's your chance of getting a baby? Now, the safety of egg freezing. There are various aspects of this. One is there an increased risk of abnormalities in babies born by IVF from egg freezing compared to IVF? Now, if we look at IVF compared to the background population risk, there is possibly an additional 0.5% risk of abnormalities in babies born by IVF compared to spontaneous fertility. Okay? When you compare egg freezing to normal IVF, fresh eggs, there's no increased risk of abnormalities. So no one can ever say that there's no increased risk of abnormalities in IVF compared to the general population, but it's a very small increased risk, and it's no different with egg freezing. And there are actually over 5,000 babies born. So that was important research to be done. If we go back to safety, there are other risks, which I'm actually going to talk about in a minute. What that woman was talking about was hyperstimulation and twisting of the ovary. So that twisting of the ovary, torsion, is extremely rare but very serious, because if it's not noticed, you can lose the blood supply to the egg. And the risk of that is about 1 in 7,000. They talked about hyperstimulation, which is when you get lots of eggs, like 30 or 40 or 50 eggs, and you get very, very bloated. Everyone gets a bit bloated, but very, very bloated. And sometimes you have to go to hospital for some fluid balance. The risk of that is about 0.4% in Australia. And there are medication. It used to be very high, especially in the US. It was about 8%, because they're sort of very financially driven and contingency plans. So they would really push the stimulation for women. And they had high risks. But now there are medications that mitigate that risk. So how much does egg freeze costing? Egg freezing that is not being performed for a medical reason, so a patient who's got cancer or some other treatment that means she has to do it for medical reasons, that's covered by Medicare. But if you don't have a medical indication, then there's no Medicare rebate, and it's approximately $8,000 to $9,500 per cycle. So it's a lot of money. You need 1 or 2 days off work, the day of the procedure, and usually the next day to work from home or not work. So you get that additional not working cost if you don't have sick leave. There have been a few studies now looking at health economics, and I'm not very good at all that health economics, and it's very complicated algorithms and assumptions. There are people much cleverer than me that do that. But there have been several studies now suggesting that if you compare egg freezing at 35 with trying to have a baby at 40, the costs are less from the egg freezing. Now, I'm just going to talk a little bit about the ethics, but I think we're going to have more of that in a minute. So this is just, I'm not going to talk about my ethics, I'm going to talk about published ethics. So there's quite a lot about egg freezing now. It's about this concept of, is it social and self-perpetuated avoidance of having a baby, and so therefore is it ethical to help these women preserve their fertility for later on when they've made a choice to do that, to not have a baby? As I said, most of the women we see are not actually in a situation where they've had that choice. And when you read the ethical literature, it talks about beneficence and non-maleficence, so the benefits, the harm, and respect for reproductive autonomy. So I just wanted to read this to you. This is about egg freezing, oocyte cryopreservation for egg-related fertility loss. So new debate both in the professional community and in society at large about the acceptability of offering this technology to reproductively healthy women who want to cryopreserve their eggs against the threat of the time. Given the many demands calling for simultaneous realisation in a short period of their lives, many women want to have children but feel under considerable pressure. So the option may give them more breathing space. It's concluded that the arguments against allowing the application of this technology are not convincing. And I just want to really realise this bit. The recommendations include the need for adequate information of women interested in this in order to avoid raising false hopes and to reinforce that the most successful way of having a baby is doing it as early as you can. And this is a position statement from our European organisation. Postponement of childbearing is not a new phenomenon that only comes into play with improvements of preservation. It explains a large part of the current need for IVF. So over 50% of the people that we see for fertility assistance are over 40. And of the patients we see, well over 60 to 70% of them, the major reason for infertility is the fragility of the eggs, usually with age. If one accepts to treat deliberate postponers, that's couples that want to come and have a baby late, we should also try and help them save their eggs at an earlier age as a form of prevention. And this is from the New England Journal, key clinical points. It says, the possibility of elective preservation of eggs should be discussed with all women who are in their early 30s, since the number of available and genetically normal eggs continually decreases over time. But women should be counselled regarding realistic expectations of the chance of pregnancy. So, weighing it all up, the downside, there are the medical risks. There's a small risk of clots in the legs being on the hormones, about 1 in 7,000, a risk of hyperstimulation, which we said was very low. The risk of infection is about 1 in 8,000. I've put hyperstimulation there small because it's really not a big issue now. It is a lonely process. Most of the women we see are in their mid to late 30s, and it's a lonely process. For some women, they have a sense of false reassurance despite everything that we say, and that is a big downside. It's very important. For other women, again, who have got false hope, they might delay addressing the harder facts about fertility and whether they want to have a baby on their own. The upside, it's an additional opportunity to have children in the future. Opportunity, I said, not a definite, to have children in the future compared to not doing it. It gives women some choice. It gives them a feeling of control when other aspects of their life are not going the way they wish. And the reality is that the complications are low. So what alternatives are there? Some women will decide to have a baby on their own with clinic-recruited sperm donation. Other women who present to have a baby when it's too late and they don't have good eggs may elect to have egg donation. Otherwise, you can just wait and see what happens. So really, we need to change the thinking about this. So what happens now is women come to us in their late 30s, they feel that they've missed the boat, and they're sad and miserable, and they see it with a sense of failure that they have to come and talk to us about this. And really what I think that we need to be doing is actually turning it around so that it should be something that you could think of when you're young and fit as an informed decision about your future if you need it. I'm not advocating it for everyone, I'm just talking about the discussion. But more importantly, what we need to be doing is improving our work-life balance and our career structures so that it is possible for women to be able to have childcare, have their children early. But of course, that's not going to address the issue of women who just haven't found a partner. So I think that we have to also grapple with the concept of what is a satisfactory relationship. So there's quite a lot of information that you can get to stay well informed. You have to be very careful and avoid fake news and fake facts. And when you look this information up, you have to look on reputable websites and look at published peer-reviewed journals. So this is what I think, this is my message really. How do we think about it? At most, it offers a small additional number of opportunities to conceive for the future. And so we say to these women, it might offer you 1 or 2 or 3 extra months of trying later on. You've got to be very clear about that. It should not be relied on as a guarantee, but it does give women a sense of autonomy and control. So we have a big research program which does receive funding from industry, but for our medical fertility program, we have no specific alliance with any drug company or industry. Just reaffirming that to you. So thank you so much for listening, and I think we're going to have another talk and then questions. Questions after?
Rabbi Greenbaum's not he doesn't feel the need for introductions. He's humble. I was going to say just that he's the rabbi of Moorabbin Shul, the director of Lchaim Chabad Kingston. He's a Mohel, he's an author, a speaker, I would say witty and at times passionate. And he's the Rabbinic counselor for Shifra, which provides Rabbinic counselling and supervision for fertility-related issues.
Thank you. I'm glad that you said it, so I didn't have to say how much I disliked the first 10 minutes of that video. It was particularly upsetting because, like you said, the couples that we're dealing with are not ladies who want to sleep around and then come in later and, I've had it all, now I want to have a baby. The couples that we're dealing with consistently are not so much couples, really. We're talking about ladies in their mid-30s, late 30s, desperate to have kids, have been desperate for a long time, desperate to be partnered, and just it hasn't worked out for them. And that's who we're talking about. And, of course, we're also dealing quite extensively with often young girls who are about to go through treatment that could impact on their fertility or future fertility. And I've dealt a few times with Professor Stern, and I have been always in awe of your compassion and your compassionate way and your way you deal with them. And I'm very, very grateful for your willingness to allow people to access halachic solutions as well as medical solutions. So thank you. And I don't think people realize what a privilege it was to hear Professor Stern tonight. So thank you. Another reason why I really didn't like that video is it didn't make sense. It didn't make sense in an Australian perspective, especially that lady who was the 38-year-old with a partner who was trying to freeze eggs. I mean, I'm not talking about the halachic perspective here, but my understanding of IVF in Australia is they wouldn't be telling you to freeze your eggs. They'd be telling you to get yourself some embryos and freeze those because, and we're going to be discussing this soon, every egg freezing is going to have to lead to an IVF, or best case scenario, or end scenario is going to lead to an IVF anyhow, and it just didn't make sense. Now, maybe she's probably doing the best from a halachic perspective, but I wouldn't necessarily say that was her point of view. So I just didn't understand the whole subtext of the entire video. But it is what it is. Let's talk about Judaism. Let's talk about halacha. Let's talk about the social implications of egg freezing. Okay, so halacha is a fascinating concept because if you look at the word halacha, I mean, people generally mistranslate it, but they'll translate it as the word law, right? Halacha is law. In reality, halacha is the way of life. It's the path. It's the outlook. It's a perspective on everything that we come across. Halacha is not like, to a believing Jew, it's not like there is my life, and then there's, okay, let's fit it into halacha. Halacha is the way of life, and it colours and it impacts on every aspect of our being. Now, many people aren't necessarily believing Jews, but in my professional career, I wouldn't say that. Many people wouldn't necessarily say they're observant Jews, but in my professional career, I've noticed there's actually 3 times that people really, really care about Judaism. There's 3 times, and they're the 3 main moments of life, really, if you will. Everybody wants to get married right. They'll be coming to Rabbi Wolf and they'll say to you, okay, can you tell me, you walk around, are you sure that's how you do it? Why do you walk around? Tell me what. And then you'll be counselling, and everybody wants to get married right. Unfortunately, you also find people want to die and bury their relatives correctly. They go to the Chevra Gedisha, they really want to know how a funeral should run, they want to do it right. And people want to have kids right. And so therefore the extraordinary thing is, and most of the couples I'll actually say that we deal with in Shifra, and Rabbi Shmuel very kindly introduced us, we're the fertility service providers for the Melbourne Jewish community. There is in Sydney, Rabbi Ullman does the same, and between the two of us we like divide up the rest of Australia. Most of the couples we deal with are actually not religious, which is actually quite extraordinary in world terms. For example, when I speak to the rabbis in Israel and I'll mention questions I'm getting from someone who's not religious, I'll say to me it doesn't make sense, because in Israel either you're religious and you do everything by the rabbis, and if you're not religious you do nothing. And Australia is a blessed society that the average Jewish person, Jewish couple, they actually want to know what Judaism has to say and how can I accord with that, especially when it comes to marriage, God forbid, passing away, and giving birth. So we're dealing with a way of life, and we're trying to hope, if we can, to the best of our ability, to help people access children, families, at the same time following the dictates and the privileges of following halacha. So what kind of halachic implications would there be of, specifically you've asked me to speak about egg freezing, and I will touch very, very briefly on IVF and other infertility procedures, but specifically let's try and limit ourselves to egg freezing. So there's a couple of issues here. A person can't do chayvel, a person can't damage himself. You're not allowed to walk up and hit yourself in the face, you definitely can't walk up and cause yourself to bleed, you can't cause yourself bruising. A person's body doesn't belong to himself. We are functionaries of God, and so therefore you cannot, for no purpose whatsoever, cause pain or damage to yourself. I had a conversation today, it's been a busy day, but I had a conversation with my local MP, and he wanted to know the Judaism's perspective on assisted dying. And I finished that, and I come here, and I start talking about assisted living of the next generation. But one of the things is, I tried to impress upon him, you cannot cause yourself, your body's not your own. We are all here because God wants us here. We all have a reason, we have a purpose, and therefore you can't cause yourself to die. You can't even just say, well, it's my body, I have autonomy, let me go if I want to go, do the same thing. Similarly, in some ways, you cannot cause yourself physical pain. You cannot cause yourself damage. There's also, which is really why it's important, and they mentioned the video, and all my readings on it, and Professor Stern mentioned as well, that IVF is no longer, egg freezing is no longer experimental. And that has implications from a legal perspective, and it definitely has implications from a financial perspective. And you can see, it's going to take some time, but the Australian government's going to start funding egg freezing for so-called elective procedures soon. It's not going to take long. Right? But anyway, besides the legal implications, besides the financial implications, it also has halachic implications. If it's no longer experimental, a person, well, it comes down to a machlokas, it comes down to an argument between some of the greatest halachic decisors of our day. If you had to sum it up really closely, is a Jewish, that would be sexist to say a Jewish girl, let's say a Jewish guy, is he allowed to have a nose job? There's no, it's an elective procedure, there's no necessity to do it. Yeah, of course, you've got the deviated septums, of course, but there can't be that many Jewish teenagers with deviated septums. So there's a fair few people who have nose jobs. Are they halachically allowed to do that? And the question is, according to Ramosha Feinstein, if this is something which would have psychological benefits, if it's something which is relatively accepted, Shem P'sayim Hashem, it's considered that this is really very low risk. Under those circumstances, the benefits plus the lack of risk, lack of self-endangerment, outweigh the negatives, outweigh the pain, the possibility of hyperstimulation, which you really, as you said, we don't see it anymore, and other things. And therefore, the accepted position mostly is elective surgery is more or less accepted under most circumstances, with a few halachic exceptions and a few rabbis who are a bit more stringent or less hesitate for allowing it. But if you can bring a good psychological reason, you can generally get it by those rabbis as well. So therefore, from that perspective, egg freezing would probably get the tick under that perspective. It really causes minimum risks, minimum pain comparatively with the psychological, social, and possible benefits. Here comes the real big one. Every egg freezing is going to end up, if you're not freezing eggs because you want to have because you want to save them, because you want to send money to Melbourne IVF or Monash IVF or City Health, or City Fertility. You want to do it because you're holding out the possibility that this egg might contribute one day to an IVF cycle. Now, IVF is really fraught halachically. It's a real questionable halachic issue. Some of the aspects of Judaism which impact on IVF, and this is what I'm constantly counselling, and I'm dealing with people, and this is one of the things we're talking about. Number one, we'll be talking about Shabbos and Yom Tov. You can't do an egg pickup, you can't do a transfer on Shabbos and Yom Tov, so that's something you have to take into account. But when I got very early into the game, when I first started getting involved and I was speaking to rabbis overseas and I was speaking to ethicists and stuff like that, and I was talking about, but certain procedures, certain pickups and certain transfers have to take place on Shabbos, and how am I to say not to? And they said to me, well, Melbourne IVF doesn't, now they do, but Melbourne IVF doesn't do pickups on Sunday. So they can play around with things in order to avoid their day, so we can also play around with things, and we can accept that if Shabbos is important enough to us, which it is, so we have to put it in early in the discussion and say, you can't do egg pickup, you can't do transfer on Shabbos. That's one thing, but we can get around that. Sperm procurement. One of the major issues of IVF is, as you said before, if I could take issue with one of your slides, you mentioned the necessities for an IVF is you need a sperm, you need an egg, and down the bottom you said luck. I'd like to say, maybe if you can just put the word God instead of luck. Yeah, okay. No, but I accept it. So you need your sperm, you need your egg. You need God. How do we get the sperm? So the obvious way is to masturbation. We send them into a room with a pornographic magazine and a jar and say, okay, come back in 10 minutes, or however long it takes the guy. But halachically, that's a massive issue. This is Torah prohibitions. So therefore, in case of absolute need, and I'm conscious of the previous Lubavitcher Rebbe's expression, Kinder haben darf man haben Mesiras Nefesh. In order to have kids, sometimes you have to self-sacrifice, if you will, of your Judaism, which is a really scary prospect, and don't use it without knowing the context. So generally, when we'll do a normal IVF cycle, what we will do is we'll procure the sperm through a sterile condom. The couple will be intimate themselves, and we will take that sterile condom and we'll utilize that. It's still not an ideal, but it's a way we get the sperm. However, the problem is, it's not so much a problem, is the lady who's coming to us and talking about egg freezing doesn't have a husband, doesn't have a partner. Now, in Judaism, we'll do certain things in order to allow for mitzvahs, in order to allow a mitzvah to take place. And we'll therefore, if you will, push the, not so much halachic envelope, but we will look at, other implications, not just, you can't masturbate, or you can't just procure the sperm. You can't cause damage, you can't cause pain. But a lady doesn't necessarily have a partner yet. She doesn't necessarily have a mitzvah, if you will, to have kids at the moment. I mean, I'm not even going to get into the fact of whether or not there's a Torah mitzvah of fertility on a lady, which I'm not sure if you know. There's actually a difference between a man's responsibility to have children, which is, according to all opinions, a Torah mitzvah of Puruvu, you should be fruitful and multiply. Whereas for a lady, it's, according to some opinions, Rabbinic, and some opinions say not even that. Now, I might say no couple I've ever met, if you look in all the halachic books, all the questions about IVF and they hinge on the fact that whether or not you allow IVF are predicated on the question of whether or not this is you fulfilling a mitzvah of Puruvu, being fruitful and multiply. That if it's a mitzvah, therefore we will allow you to do certain things in order to be able to fulfill a mitzvah, your cost-benefit analysis. If it's not a mitzvah, we might be less willing to allow you to do certain things which are halachically questionable. No couple I've ever dealt with, and I doubt very much, really cares or not if it's a mitzvah. People just want kids. People just want kids. Possibly, this is, it has been said before, the reason why it might not actually be a Torah mitzvah for ladies to have children where it is for men is because, and I'm not saying it's every couple, but every couple that I've dealt with, there's always, in every IVF couple, there's a driver and there's a passenger. There's a driver who's the one looking out there, looking at the next appointment and calling up the doctor and doing the research and Googling and what's the next step and who are we doing to next. And there's always the passenger who says, oh yeah, didn't we just have an appointment last month? I'm not sure if those are the terms you use as well, but there's drivers and passengers, and more often than not, I actually can't think of a single case of a couple that I've dealt with that the driver wasn't the lady. But here we're talking about a situation where she doesn't actually have a mitzvah. She's not married. And although this isn't extensively discussed, and the reason why it's not extensively discussed is because, as you mentioned, this is really a new field. Egg freezing is really new. It's been around like 10, 15 years, but as practical for the masses, it's really only, we're talking about 3 to 5 years here. So the closest thing you can have is the discussions of Moshe Feinstein and others of a 16-year-old boy who's about to have chemo. 16-year-old boys are about to have chemo. The question is, can we send him off quickly to a lab to grab some sperm off him, in order to provide him future options, possibility of fertility if the chemo has the effect of impacting on his sperm count. And according to many of the great rabbis at the time, they said a 16-year-old boy, 17-year-old boy doesn't have a mitzvah yet to have kids. He will one day, once he has a partner. And once he has a spouse, and then he wants to have kids. But at the moment, can you say that one has a mitzvah before one isn't obligated in it? It's an extraordinary question. The same thing is true here. Even if you say a lady does have a mitzvah, even if you say a lady does want to have kids, and we're really talking about a psychological need here, as opposed to a religious need, if you will. Because before you have a partner, you don't yet have a religious need to have kids. You've got a burning desire, you've got an aspiration for the future. And I'm not discounting that, but it is not necessarily a religious need. And so therefore the halachist has to take that into account when he's actually discussing with the typical case of a 34-year-old girl who wants to preserve her chances. Now, you could also say, if you put it on the other way, you say that actually this actually gives her more opportunity and more chance of actually meeting the guy in the future and then one day having the child. Because I was listening to a tape from YU Torah. I was listening to a Rosh Yeshiva from Yeshiva University, which is more the modern Orthodox stream of Orthodoxy, and he was saying, one day, the same thing as you do these dating profiles and you tick off, are you a bachelor or a graduate? Those are the two options, right? Are you right wing or are you left wing? Do you want to live in Israel? Do you want to live in Israel? One day they might have a little checkbox. Do you have eggs frozen already, or do you not? And that might be one of the things that people take into account when they're actually pursuing the shidduch. Otherwise, you'll have the situation he was describing of a 43-year-old guy who, the way the rabbi very, very kindly put it is, he's got a weight profile like mine, and I'm listening to a tape and I'm still assuming I've already got the picture in my mind, only wanting to go out with 25-year-old girls because he wants to have kids. Whereas if anything, maybe the possibility she's got her eggs frozen actually opens up the possibility of the marriage market for her, besides having the psychological benefits of the fact that I might one day be able to have kids, and please God I will, and number one, I might not necessarily need these, because it actually will open up it will take down some of the barriers, it will take down some of the fear factor of someone marrying this girl who's 38, 39 and saying, will she ever have her own kids? And here we come, so IVF is a massive issue, but halachically, we can pretty much the same. You're not actually doing anything wrong in freezing eggs. You might one day come to needing IVF, and that might have halachic implications. But by then, you've got please God a partner. By then, you've got please God a husband, and then you've got the mitzvah. And all you've done is bingo. You've actually just solved a conundrum by having some short-term pain in the past. So you can get by that, and it's actually beneficial. And it's actually many rabbis are actually recommending it now. And why they're recommending it, and here's the real implications of allowing egg freezing. And you touched on this, but let's repeat it along. What are the alternatives if we don't allow egg freezing? And I'm going to put this back to, for example, there's a concept, it was mentioned, I'm sure if it was Professor Stern or was on the video, they mentioned PGD, pre-implantation genetic diagnosis, which is that we'll do a couple with a known genetic issue. Tay-Sachs, everyone's heard of Tay-Sachs, they're both carrier of Tay-Sachs, so therefore instead of having a child unprotected intercourse, which could lead every single child might have a 25% 1 in 4 chance of actually being getting both genes, and therefore they'll end up, God forbid, with Tay-Sachs. So what we'll do nowadays is we'll do pre-implantation genetic diagnosis, they'll do a IVF cycle, they'll produce, in best case scenario, let's say 6 embryos, 6 embryos, they'll go on day 5, and right before the blastocyst stage, the 8-stage embryo, they'll hive off one of those embryos, 8 cells, sorry. They'll hive off one of those cells by micromanipulation. They'll examine it to make sure that there is not a carrier of Tay-Sachs in our example, and the ones that aren't, they'll put back in. Now, there's massive questions about whether or not you're allowed to do PGD. It's IVF on steroids. It's IVF plus. All the halachic questions you've got about IVF are just more. But one of the greatest rabbis of our generation, Rabbi Elisha, who basically founded the field of Jewish fertility, the former chief rabbi of Israel, former Sephardi chief rabbi of Israel, his rationale for allowing PGD, he says, because what's the implications? If we don't allow PGD, what's going to happen? People are going to get pregnant. They're going to do, well, in those days it was you check to see whether or not, nowadays they do a non-invasive blood test, and then they're going to lead to abortion, which is far worse, far greater halachic implications than letting someone do PGD in the first place. Follow? So let's look at the implications if we don't allow egg freezing. What kind of implications are there? People are going to do one of two things. You've got a 34-year-old, 35-year-old, 36-year-old girl who's desperate to have kids. She wants kids. It's a natural human and humane desire to want to have, not to be left alone, especially because she doesn't have a husband. Even worse, she doesn't want to be left alone. She's going to, it's happening more and more. And at the time when the rabbis in Israel got together and they went from egg freezing to egg freezing, they were actually seeing more and more girls who were actually getting themselves pregnant as single. There's 2 ways to get yourself pregnant. Well, there's 3. There's the easiest way. That's the least recommended halachically. Let's put that aside for now. There's the other way of getting yourself pregnant when you're single, which is through donor sperm, either from a Jew or a non-Jew, which has profound halachic questions and implications. And on top of that, you've got this real questions about, is it fair? Is it halachically just? Is it something acceptable to bring a child into the world? We're talking about, everyone will start talking about the mother's rights and she wants to have kids, but you're bringing a child into this world without a father. You're bringing a child into this world to a single parent. Now, a single parent house is not necessarily anything necessarily wrong with it. We'll do our best to nurture that mother, that nurture that child. The community will be there for them, but it's not something we want to contribute. It's not something we want to bring about more instances of. And under those circumstances, if you say to her, okay, don't have the child now, not by donor sperm, have yourself preserve your fertility. Hopefully you're doing it early enough that you actually get decent eggs. Please God, you'll find very soon, and we pray for you, and we'll do everything, which is our responsibility as a Jewish community to help people find shidduchim. And then, so-called, you've got your insurance policy. Worst case scenario, if you can't get pregnant naturally because you've missed that vote, you've missed that possibility, but at least you're bringing a child into the world through IVF, from that frozen egg to a couple, to a family. You and your, please God, husband-to-be. And let's say even that doesn't happen. We're not even worried about that. You're not even worried about the child is not going to be born into, she's not going to give birth to a child while she's still single. She's going to wait till she gets married. Let's say then it's too late. Let's say she can't get pregnant then. What's the other implication of not allowing egg freezing once she's 33, 34? The other implication is that now she's 42 and she's met the guy and she's happy and she wants to have a kid. She can't get pregnant naturally. Here we start getting a question of donor eggs. And donor eggs is extraordinarily difficult from a halachic perspective. I could start quoting you shuvas, I could start quoting you rabbis, that they would say that's absolutely forbidden according to most, many, I don't want to generalize in a public forum, but it's an extraordinarily difficult question. It's a different question. The question is, can she freeze her eggs just in case? And so therefore, if you take this a summation of all I've said, it's not actually necessarily chayvel. It's not necessarily causing pain. It's not necessarily causing damage. And even if it was, the risk justifies it. The IVF issue, right now, she might not have a mitzvah to have kids, but from an IVF perspective, she's not doing IVF right now. She's freezing an egg, which may lead to an IVF. Even in worst case scenario, she might not need the IVF. And you've got the psychological implications. And here, when I mention psychological implications, let me just finish off one other concept. A mentor of mine was once asked, that situation I mentioned before, of a 16-year-old boy who's being asked to save some sperm. 16-year-old asked me to save some sperm, he's about to do chemo. And I told him it's a massive, massive halachic question. It's a massive halachic question. He's not yet mechuyev in having kids. He's not yet obligated to have children. My mentor actually allowed him. He said to him, yes, under these circumstances, your circumstances, he actually said, go off and procure some sperm that way. The boy came back to him a year later and said, I want to tell you one thing. When everybody was telling me to have chemo, and they were telling me I've got cancer, and I was saying, you know what, I'm going to die. And they're just not telling me. They're just not telling me these things. It was when you told me to save sperm, it was the first time I actually woke up, hey, they're anticipating I'm going to live long enough to have kids. They're anticipating I'm going to live long enough to have a wife. They're actually giving me not just hope for a future, they're actually telling me that I will have a future. That's a true story that I was involved in. That's not my pay scale to be able to allow that halachic question, but I sat there with them and we did the saving of the sperm. Taking that story to its logical possibility, is there not a possibility that if we allow people to, and we actually encourage people under the correct circumstances to freeze their eggs, we're actually not just telling them, oh, we'll pat you on the back, as you mentioned before, you poor little person who's 34 and you can't find your spouse, and therefore we're going to give you something like, a little toy to make yourself feel good in your loneliness. We're actually telling you as a community, we're expecting that, it might not have happened for you the way you wanted till now. And your life might not have been, when you were in grade 3, you drew the little picture, first comes this, first comes that, then I'm going to have the 15 kids, and I'm going to all these things, right? It might not have happened the way you want, but we're actually at every expectation that any moment now, please God, you will find happiness, you will find a husband, you will find life. And we are actually telling you, we have the expectation, okay, hopefully these eggs won't even be necessary. They won't even be needed. But if they are, we have every expectation that the halacha, the way of life, which we believe is all-encompassing, that is there for you and is there for you at every single stage of your life, is there for you now and will, please God, be there for you in the future. I don't even have to rebut, which I was going to say before, because you did it so well. The thing is that, just because we allow you to freeze your eggs, don't go pushing off having kids. Nobody needs to be convinced that Judaism values children and we want children right away, we want large families. You don't need to be described that. So I'm just not going to go there. Two other things I have to say. If one is doing egg freezing, it must be done under hashgacha, it must be done under halachic advice. And those eggs, what my team do and what my organisation do is we will be there at time of egg pickup. It doesn't look like, I got to tell you one thing, the IVF eggs, they do not look like that. They do not look like that. But we will be there for you. We'll have a mashgicha there in the room. When they take those eggs back into the lab, we will be there when they freeze them, the vitrification process. We'll have it sealed. Please God, you will never need them. They're just there as an insurance policy, a very expensive insurance policy. They're there. But if you do ever need them, we will be there as well as under hashgacha, making sure that it's the guy's sperm, that it's her eggs, that child, no one will ever have a halachic question on them. Nobody will ever. Number one, that way you're according with the needs of halacha. And number two, no question will ever be able to be raised about the paternity or maternity or the Jewishness of this child. So that's number one, is absolutely, yes, you can be assured that we'll be there for you. Here in Melbourne, it's myself and my organisation, Shifra, and I'm happy to talk to anyone at any time. And the last two other things, number one, Jewish Care have a free loan fund. It is expensive. It is expensive, as you mentioned. Jewish Care have a free loan fund and they will happily use it for medical advice. And so therefore, and if people need, I can put them in contact, or you can just call up Jewish Care. They're sitting on a lot of money. They're desperate to lend it out. So it's the type of thing that people can access if they need. And the third thing that I just thought it's important to me, let's please God, someone has frozen their eggs, and then 3 months later they found their husband and they're happy and they got married and they've got 15 little kids running around, and what do we do with those eggs? What do we do with those eggs? They can be disposed of. They'll be disposed of under halachic supervision, the same way as they were made under halachic supervision, but we have less of an issue from a value, if you will, by the way, you mentioned that the big drivers of egg freezing, you mentioned it was animals and stuff like that, but actually some of the other drivers are Catholics who couldn't do, they couldn't freeze embryos because they believe that's life, so therefore they'll freeze eggs instead. And so, for example, Italy, which is a world leader in egg freezing for that reason, because it's the only country in the world that they're not allowed to freeze embryos by law. But we don't have those same issues from a Jewish perspective. An embryo has value, but it doesn't necessarily have life. So therefore, it can be disposed of, but like everything else till now, it should be disposed of according to halacha, which is what we're here for. Thank you so much for your time.
Thank you very much, Rabbi Greenbaum. We will have several questions with everyone, and then after that, other individuals with questions can come over to the speakers and ask their questions.
So I wondered, Professor Stern, now that egg freezing is no longer experimental, is the use of donor egg declining? And I wondered from the rabbi why you seem so virulently against donor egg. If you've got people who are having children, 15 wonderful children running around, and they have these beautiful eggs frozen, why can't they donate them to another Jewish family?
Yeah, so I think egg freezing hasn't been around long enough outside the cancer spectrum to show a discernible reduction in egg donation. And also we have more and more women wanting to have babies, and because there is the availability of egg donation now, we haven't seen it. But hopefully, we're really hoping that we will see a reduction. Now, just before we pass on to Rabbi Greenbaum, you raise a very interesting point. So there are some people that suggest that if you don't use your eggs, later on, could you then donate those eggs that were taken in good faith, not for commercial value? And that's a very interesting concept that we are obviously sort of exploring in a theoretical sense at the moment. But, you know, one of the problems that in Australia, donation has to be altruistic, so you can't get paid. So it's very hard to find eggs from a young woman who's ready to donate her eggs. There are lots of women who have finished their families who are happy to donate eggs, but they're 35 to 40, and so the chances are going to be much lower. And a lot of our patients will go overseas because they can't procure eggs from someone young. And they want to be able to have identity release, and they want it to be altruistic, but it's just not possible here. So this might solve that problem.
So I would answer the same thing. Practically, people don't want these eggs, right?
I don't think that's true.
34, 35-year-old people's eggs, they don't want them.
Well, they do if there's a genetic connection or a religious connection. But just if you're just talking about the chance of success, you've tried for treatment for a long time, you haven't been successful, you're really at the end of your energy level, and you've got one little thing left in you to have a go. If you could have eggs from someone who was 25 compared to eggs from someone who was 35, you might choose the 25-year-old. But, you know.
But if you want Jewish eggs, I guess my halakhic question is...
So halachically, donor eggs, I wrote down a few sources. I thought it might come up. I wrote down a few sources. Problem with donor eggs. Look, there are multiple issues. Some people say it might lead to problems of potential incest if there's multiple children from different homes, if you will. There's the purity of the bloodlines, although it sounds a very, very Nazi type of expression, is something. But yichus is a much nicer way of saying it. Is an extraordinarily important thing to Jews. And if you want, I can send you some articles discussing what exactly are the halachic implications of donor eggs and why that is very, very far down of the list of recommended research.
But if an embryo came from a Jewish woman's womb, be it her egg or someone else's egg, that halakhically that child is considered Jewish?
No, there's massive questions about that. If it really comes down to the question of what constitutes maternity in Jewish law. Is it biological? Is it biology? Is it genetic? In other words, is it the egg donor? Is it the person, gestational carrier? Is it both? Right? And so you just assume that it's Jewish is not necessarily so.
So you're saying that if a Jewish woman gave birth to a child from a donor egg, that child would then have to convert to Judaism?
Again, it's not exactly tonight's topic. Tonight's topic is egg freezing and not donor eggs. But if you want to know what the Melbourne Beth Din do is, Melbourne Beth Din, see, it's a two-part question. Surrogacy is where the donor mother, if you will, is Jewish, and the gestational mother is not Jewish. Egg donation is almost the exact opposite. So to claim both would be Jewish is a logical possibility, unless you say you only need one of the two. The Melbourne Beth Din, what they paskin, and that's in accord with my understanding of all the major Beth Dins in the world, is both in cases of surrogacy from a non-Jewish surrogate and in the case of egg donation from a non-Jewish donor, they will recommend what's known as gir misafek, which is a conditional conversion based on lack of knowledge. So under both circumstances, they will convert the child. It's not exactly as difficult, if you will, as a full conversion of an adult, but they will actually recommend a gir misafek in situations which we do quite often. But again, it's not exactly today's topic.
I had the good fortune 2 months ago to be at a Jewish Medical Ethics Conference in Zurich for 5 days, and the leading ethicist there was Professor Rabbi Steinberg, and there were a number of others and a number of scientists, and everything I heard today is very much was echoed there. But they raised a very interesting point in context of your last question. In Israel till now, there has not been any recording of sperm donor's identity, and they're now just passing legislation so that the sperm donor's identity is going to be recorded. You will not be able to identify who that is, but they will be able to tell you if it's a case of incest. Because in Israel there's a very high probability, not high probability, but much more significant probability in a smaller population base in terms of that, of possibly that taking place. That's number one. That was just an interesting point that they raised there. And the other thing is that in many, many countries of the world, they also likewise don't have a record of sperm donors, and that complicates the whole issue of utilising a sperm donor bank in terms of halakhic aspects of it. And the question I have of Rabbi is, at first instance, there may be some questions on egg freezing, but ipso facto, after the event, is there anything that you would say forbids the use of the egg?
Frozen under supervision?
Under supervision, yes.
Well, the whole question about the IVF, it's still the ideal is to have a baby that... So,
sure.
First time I walked into an IVF lab, I was watching an ICSI, which is, again, like IVF. Are you familiar with the term?
Yes.
So normal IVF is that, you put them together. They don't use a test tube, they never did. They use a petri dish, and the eggs and the sperm, and they hope. Whereas nowadays with ICSI, especially for a person with a low sperm count, they will actually sit there and you can actually watch on the monitor, and they'll grab the one sperm and they'll push it, and they'll put it into the egg, and you're actually watching that moment of conception. You're actually watching, you're watching Genesis. It's the most extraordinary thing in the world, and I was just blown away. And the embryologist turns to me and she goes, "I've got to tell you, the natural way is more fun." So, is there anything wrong with using once those eggs are thing? It's an IVF. It's an IVF question. You still you'd rather do it without the IVF.
That was the consensus of that conference also. The only thing that they have problems with the reasons that you raised, and they are not the process-generated questions, but social implications of delaying the onset of motherhood. And what that means in terms of future generations, or what that means in terms of single motherhood, what that means in terms of...
Interesting is, halakhically, you're far better off. A non-married lady having a child is halakhically far less questionable than, for example, the donor egg, donor sperm, and all that.
Mm-hmm.
Because, as you said, the sociological implications of that. So, for example, Pua, which are the world leaders in fertility and halacha, they will not facilitate a conception of a non-married lady.
Okay. Professor Stern.
Can I just answer a couple of those questions?
And we'll just have maybe one more after you, and then we'll make it private.
Sorry, just quickly.
In Australia and in America and in most countries around the world that do sperm donation and egg donation, well, egg donation is always directed. With sperm donation, there is a family limit. So in terms of the risk of incest, etc., so it is 10 families in the country. And there is even in the days when it was anonymous, you couldn't find out the name and the details of the sperm donor, all the details were always kept. So I think it's very different here. I'm not sure about Israel. No, only in that one case that was on Today Tonight.
No, they've been subsequently destroyed though, because they promised anonymity to the donors, and so therefore.
So they weren't destroyed. They promised anonymity, but that has now been challenged successfully in legislation. So that's the first thing I want to say. The other thing is I did have a slide, but I took it out, which is just talks about having a baby as you get as an older woman, not the egg-related issues, but just having a baby, and the medical impacts are really only significant once you get to the very late 40s. And importantly, there's no increased risk of postnatal depression or acopia in women in their mid-40s, early to mid-40s, which I think is a very important point.
So your eggs degenerate, but your ability to bear a
Yeah.
child in term do not.
Yeah, there are the more challenging issues of how old are you going to be when your child turns 18 and has a baby, and that's obviously the subject for another discussion.
Maybe just final, you wanted to ask something?
What's the percentage of, not when freezing eggs, but when freezing embryos, or freezing the man's sperm, and when the woman take the egg from the woman and make it into embryo and then inject it back into, what is the percentage of it being live birth?
So that was the data that I showed you before. So if you freeze embryos rather than freezing eggs, the pregnancy rates are the same and the live birth rate is the same. And when you look at data, everyone's worried about the difference between clinical pregnancy and then live birth. And some people, there was a thing on Channel 2, ABC, sorry, I'm old-fashioned, where they talked about this conspiracy of not using live birth rates. But the live birth rate is the clinical pregnancy rate minus the miscarriage rate. So it's not, the drop-off is sort of approximately 20%, and then, but more if the woman's older.
Okay. There's a lot more to ask and a lot more to discuss. We're going to officially close this evening, and if perhaps the speakers stay another few minutes, great. I wanted to tell everyone here that this is the first of a 4-part series on medical ethics. We're going to be having sessions in the coming weeks. Actually, Rabbi Greenbaum alluded to a number of the issues that we're going to discuss in the coming weeks. Next week is about cosmetic surgery. The following week is about animal experimentation. And then the 4th part will be about gene selection. So we have definitely next week's, and I think also we have the flyer for in 2 weeks out the front, and we'll be sending out the flyer for the 4th week gene selection in the coming days. I really enjoyed and learnt from both presentations, and it was also interesting how you had many views presented within a video, and then Rabbi Greenbaum suggesting which ones were fit with traditional Judaism and which didn't. I'm very thankful to Professor Kate Stern for being here, and Rabbi Greenbaum, and on behalf of Spirit Grow, we just have a small token of our thanks. Okay, good evening and thank you.